Our distinguished guest speaker today, Dr. Hans-Rudolf Tinneberg from Germany. He is the founder of the European Endometriosis League, and he is the honorary president of this society. And you can see his CV at the application. Very, very busy CV. He graduated Kiel, and after that, he was at the university. His main interest, endoscopy and gynecology, and endometriosis and other reproductive medicine issues. Now, today, he will speak about the medical treatment of endometriosis. Please.
Thanks, Engin. Ladies and gentlemen, welcome to this lunch symposium. I'm very grateful to the organizers of having me here. It's wonderful weather in Cyprus. It's sunny. Back home, it is very cold and ugly. And I'm very grateful to you for being here right now at this time, because I think it is a big conflict having lunch outside and being in here. You had wonderful presentations in this morning talking about very specific aspects of reproductive medicine. And now I'm sort of taking you back to something very basic, which is endometriosis. All of you know that endometriosis can be a severe reason for infertility, and it is very important, since this is also a debilitating disease for many women suffering for many years sometimes of pain and of other problems, to get rid of it. Now, my topic is medical treatment of endometriosis, and I must confess I am basically a surgeon, and I love to do endometriosis surgery, particularly in deep infiltrating endometriosis. However, I must admit there is definitely a role for medical treatment. I want to go through the portfolio of medical treatment, and before starting, of course, I'd like to share with you what a gynecologist, and all gynecologists are good doers. They want to do the best for their patients. So what do they want from a medical treatment? Of course, it is that they want to improve the quality of life. They want to reduce the lesions itself, and they want to improve fertility. They want to make sure that there is no recurrence. And of course, this is a huge portfolio, what we want to do. Now, what are the treatment options? On the right-hand side, on the left-hand side of this slide, you can see the entire portfolio of medical treatments, and on the right-hand side, you can see the surgical options. Of course, at the very beginning is the gynecologist's best child, it's oral contraceptives. Oral contraceptives are usually the first choice to deal with. But we also have to consider progestins only, GnRH agonists with ADBAG, levonorgestrel, also including the iodine Mirena, Danazol, aromatase inhibitors, non-steroidal anti-inflammatory substances, and complementary alternative treatment. Complementary alternative treatment has become en vogue because people think this might be natural, this is not so harmful, but also we have to see that it, in many cases, is not at all efficient. Now let me just share with you the CAM procedures, and you will see these are all substances that are good for many, many things. It's good against cancer, it's good against Alzheimer's disease, so it has to be good against endometriosis as well. Resveratrol, the first substance here, as you know, in low quantities, it is available in red wine. So if you drink a lot of red wine, but I think you have to drink one bottle to have efficient amount of resveratrol, it might also help against endometriosis. Green tea, polyphenols, green tea, very good, as I said, against cancer and against many other things. Curcumin, a substance that might be available in Turkish kitchen, I don't know, but curcumin, at least in Arabian and Asian kitchen, is very common. It might help against endometriosis. It is said also to be helpful against myomas. So if you ran out of ideas, you might add curcumin. Puerarin, of course, too, and of course, ginseng, a very common substance. And if all of that doesn't help, you might go to more dramatic procedures like acupuncture, moxibustion, and hermal enema. These enemas have to remain in the rectum for 5 to 6 hours, so it will not be really comfortable to have this therapy, but sometimes this has a very high placebo effect. And of course, microwave physiotherapy and osteopathy might also be something that might be part of the portfolio of alternative and complementary medicine. I mentioned before that oral contraceptives are the best loved child of gynecologists. At least this is, in my country, very common, even though we have to know that this is a very difficult aspect. Of course, when applying combined oral contraceptives, it is that we have to not to talk about the cyclic application, but we have to talk about the continuous application. Cyclic application does not prevent bleeding and therefore does not prevent the stimulus for a new transplantation-induced endometriosis. Now the next is progestin-only oral contraceptives, where that might be an option. And as I said before, this is a very frequent therapy. It has few side effects, and it is less expensive than some other therapies. But in most cases, it is shown to be inferior, definitely to GnRH, and definitely also to Dienogist, and this is in brackets, also danazol, because danazol, because of its massive side effects, has been taken off the market, at least in Germany. Oral contraceptives in Germany are off-label, which means that the insurance company will not pay for this type of treatment. And we know that there is a quite recent publication from Chaperon in Paris, where they found in a retrospective study that oral contraceptives, combined oral contraceptives, might increase the risk of deep infiltrating endometriosis. This was found out later, and this was also found out after they stopped treating this, and then suddenly, you know, when they stopped the treatment, during the treatment everything was fine, but then when they stopped, suddenly there was more pain and more problems than when at the time when they started oral contraceptives. And you know, Vercellini, he also has published on oral contraceptives and risk of endometriosis, and he found out that there might be a masking effect of oral contraceptives to endometriosis, but that also underlines the findings of Chaperon that this is not a true effect on treatment of endometriosis. Now, long before GnRH analogs were the gold standard of endometriosis treatment and of treatment of uterine fibroids. And we know that GnRH analogs are equally effective in reducing pain, the same as with danazol, again in brackets, and progestins. And we also know that with GnRH analogs, there is some problems with implants, with endometriotic implants. So unfortunately, it is very difficult to tell for sure that if you apply GnRH analogs, that you reduce or even eliminate the implants. So of course, as you know, when you stop the therapy, these implants, the same as with fibroid, the implant as well as the fibroid start to grow again. So that's a problem. And we know from some other studies that combined oral contraceptives are not as effective as GnRH analogs. Now, there are quite a number of side effects associated with GnRH analogs. And I'm talking so much about GnRH analogs because a long time ago, until recently, GnRH analogs, as I said, were the gold standards. And we know that they are safe and effective, but you have to apply simultaneous add-back therapy. And if you do so, of course, sometimes you mask some of the effects of GnRH analogs. I know of a lady from South Africa because at that time it was the only GnRH analogs were the only drug that helped her. So she did not feel well with add-back therapy, but she felt well with GnRH analogs. Of course, she then had a massive problem with bone mineral density. Now, add-back medication can prevent bone mineral density, but if add-back therapy also means that the effect is not as good, then of course you are in troubles. Now, what is the duration of GnRH analog therapy? Of course, first of all, 3 months are just as effective as 6 months, but when you stop the therapy, you know, you will have a flashback of this therapy. There are other publications saying that 6 months has a longer recurrence-free interval than only 3 months. And of course, again, monophasic oral contraceptives are not as efficient as GnRH analogs. Now, those like me who are surgeons can say, okay, we restrict ourselves only to surgery. Surgery will fix all the problems. There's an interesting study showing what is the recurrence rate if you just apply surgery or if you apply surgery with a medical therapy that is following the surgery. And I think you can clearly see that the recurrence rate of surgery alone is much higher than if you perform a post-surgery medical therapy. So therefore, we have an indication to not only treat those patients that probably do not need a surgery or that do not want to have a surgery, but we also need to treat those patients that had surgery in order to prevent recurrence. And you all know that unfortunately endometriosis is a chronic disease. Chronic means as long as this patient is hormonally active, she will suffer from this disease and she will have a high recurrence rate. And usually, at least in my experience, and we are one of the biggest IVF, not IVFs, and endometriosis centers in Germany, the recurrence rate is fairly high, and recurrence occurs usually after 2 to 3 years, depending also whether the woman had become pregnant or not, or whether an infertility treatment had been applied. Then the time interval is rather shorter and might be closer to 2 years than to 3 years. Let's talk about progestins. You know, why at all think about progestins as relevant for treatment of endometriosis? And you can see progestins do have a clear effect on eutopic endometrium. This is not what we want. You know, we want to treat the ectopic implants of endometriosis. And you can see here there is reduced cell proliferation, there is improved cell differentiation, which is very important. We have reduced uterine contractility, which also leads, there are some studies showing that women with endometriosis have a wrong contractility of their uterus. The uterus pumps the blood during menstruation back into the abdominal cavity. Therefore, thank you. Therefore, they have retrograde menstruation, whilst normal women not suffering from endometriosis have orthograde contractility of the uterus. And of course, the bleeding is reduced. In ectopic endometriosis, if we apply progestins, we can increase the apoptosis of these cells. We have an immunomodulatory effect, and as you know, basic research in endometriosis shows us that there is also an immunological problem with endometriosis patients. Very, very important, there is an anti-angiogenic effect, which could be clearly demonstrated in vitro studies, and very important, there's also an anti-inflammatory effect, because the inflammation seems to be the main problem to cause pain. Without inflammation, there would not be pain for endometriosis patients. And this is enough material for a one-day lecture, pain in endometriosis. This is very difficult and also very important. Now here you have an overview. As all of you know, progestins is a big group, but we can subdivide this group into the C21 progestogens, into the C19 testosterone progestogens, and into the spironolactone. And you can see dianogist, which is the other substance that is approved for treatment of endometriosis, belongs to the C19 testosterone derivatives, and you can see this is part of the estranes. Now, when looking at it in more detail, we can see this is the formula of dianogist, and dianogist is a progestin that combines properties of both the 19 testosterone derivatives as well as the progesterone derivatives. And what does this in particular mean? It means that for one, we have a strong progestational effect on the endometrium, which is very helpful. We have relatively short plasma half-life of appropriately 9 to 10 hours, which is very important because if you have a daily application that you do not get an accumulation of this substance, and we have a very high oral availability, which helps that this substance is easy to digest. Now, the second part, the properties of progesterone derivatives, is we have an anti-androgenic effect. That's quite helpful because this also helps some women, but also a very good tolerability, no effect on metabolic aspects, and no effect on vascular, hepatic, or central effects. As all of you know, hepatic effects of some of the hormonal drugs have been very much into discussion, and since this is a biosymposium, you all know that some of the substances had been accused of even causing liver tumor. Finally, it turned out not to be relevant, but there is always this idea there could be an effect on liver. Now, relatively moderate inhibition of gonadotropin secretion. This is also very important because if you have a complete inhibition of gonadotropin secretion, you would not have this background activity of the ovary, and you would also suppress the estrogenic effect so that there would be no estrogens available. So only a relative moderate inhibition is very good, so that there is mainly a peripheral mode of action, and of course that means that there is the beneficial effect of estradiol action on bone, central nervous system, and central venous system. The mode of action can be separated into the central effects, inhibition of gonadotrophins and ovarian function. This is this axis, and it can also be the local effects. And as mentioned before, the local effects are the ones that make the beauty of this substance, because they are anti-proliferative, anti-inflammatory, and anti-angiogenic. And if you really want to impress your patients, please learn this by heart, because there you can be really brilliant. You can show, of course, you know, there is the anti-inflammatory effect, NF-kappa beta. There is the local effect because the aromatase is inhibited, so that we have a local at the area of the implants, a local effect by lowering the estradiol content. And of course, it also has some action in the prostaglandin cycles, and it reduces the prostaglandin E2 level. So therefore, it is quite clear that this is a very effective substance. Now, when you have this substance, and mind you, this is not a new substance. This substance was primarily introduced when Germany was still two countries, you know, a socialistic country and a more capitalistic country. But it was introduced or invented for contraceptive use. But then it was found out that it is very good contraceptive, but it is even better in preventing endometriosis. Now, when you when you want to prove this, you have to prove it against the current gold standard. And that's why a study has been implemented showing that Dianogest was tested versus leuprolide acetate. And I just go with you quickly through a few slides. First of all, we see that reduction of pelvic pain, which is the most important aspect, because this is the debilitating thing, is absolutely the same, whether you use GnRH analogs or whether you use leuprolide acetate. Now, when it comes to differentiating the pain aspects, you can see these are the VAS, the visual analog scale for pain. This is a standardized formula. And you can see, because, 10 is maximum pain and 0 is no pain. So it depends on how many centimeters in this row it was reduced. And you can see in the lower aspects, leuprolide acetate is more or less leading. This is not statistically significant. But when it comes to 4.5 centimeters decrease, there is a Dianogest ahead. And also, when it comes to this file, you can also see it is 75%. There is Dianogest ahead of leuprolide acetate. When it comes to quality of life being probably one of the most important aspects, because this is all together. It is, of course, pain, but it is also more than pain. And you can see here, this is mental health and this is physical health summary. And you can see that Dianogest is, in this case, is far ahead of GnRH analogs. And this is quite obvious, mainly due to the fact that GnRH analogs, because of the reduction of estradiol to basal levels, does not encourage a good feeling and a good healthy life. So when it comes to quality of life, as you can see, Dianogest is far ahead of leuprolide acetate, just when comparing these two aspects. Hot flushes, this is something that is not surprising at all. Hot flushes are very high in leuprolide acetate, but there are hardly any hot flushes in women subjected to Dianogest, and the same applies to bone mineral density, which is also, when you apply only GnRH analogs, there is a loss of bone mineral density. Therefore, GnRH analogs are definitely no good drugs when it comes to treating young patients. Something that is very, very important for every woman is, of course, body weight. Body weight, in my experience, sometimes seems more important than pain and other things. There's only one thing that might be in competition with body weight, and that is hair loss. If a woman loses hair, terrible, So she might even accept gain in body weight if the hair is growing again. But anyway, body weight, as you can see, there's hardly any effect on body weight when comparing GnRH analogs to Dianogest. Now, when talking so much about Dianogest, let's have a look at the long-term use of this substance. And this is again explaining a study to you, and you can see there is a comparison of women subjected to Dianogest and to placebo. And surprisingly, also placebo does have an effect. And that is where I come back to the COM procedures, the complementary alternative medicine. So you will always find women that say, oh yeah, I got this ginseng or whatever, it helped me. But it is by far not as pronounced, and it will not go further below. It will stay and it will come back. That's the experience. Now, in this study, there was a switch, and women that were on placebo then were put onto Dianogest without knowing. And they then reported that they had more pronounced effect on control of pain. Now, this went on for as long as 65 weeks, so quite a long study. And people wanted to know, and this is a study by Petraglia from Siena, and he said, okay, we continued observation after we stopped the treatment. And it was found out that there is a sustainable effect, so that it did not return back to the initial stage of pain, but that it stayed at a fairly low level, which is what we want. We do not want to always only have the effect of the treatment when we treat, but there is also a prolonged, a sustainable effect after we stop the treatment. So what one might think of is one might have an intermittent therapy. So you give it for some time, then you stop and you give it again. At least this is something that you can talk with the patient about. But in my experience, most patients, once they got helped and they feel fine, they want to continue this treatment. Let's have a look at what societies say about it. This is World Endometriosis Society, and especially referring to young women. They clearly state that the management of pelvic pain should not be delayed in order to obtain a surgical confirmation. So what we did in Germany first was endometriosis is only when you have a specimen and where the pathologist told you this is endometriosis, and only then you should treat for endometriosis. And these are probably the patients that might even benefit young patients with severe dysmenorrhea. They might be the ones to benefit from oral contraceptives. Now, in those patients where oral contraceptives are not at all sufficient, where they only reduce pain and whatever at a low extent, there I think we should look at the ESHRE guidelines. Even though they are updated from 2013, I think they need a new update, because meanwhile we have some new data too. And they say, counsel women with symptoms presumed to be due to endometriosis thoroughly and empirically treat them with adequate analgesia, combined hormonal contraceptives or progestogens. Now, with respect to combined oral contraceptives, we meanwhile have data that say this is not the best treatment to go. And I would very much like to share with you a patient from my consultation. And you can see here, this is a woman that came to me. She came from fairly far, and she says, whenever I have my period and whenever I'm menstruating, I have my eye turn red, and it is painful, severe pain. So I sent her to the ophthalmologist. This is the photo from the director of the eye clinic of my university. And the professor said, okay, fine, I can understand that this is endometriosis. We need to take a biopsy. And you can see why she said I need to take a biopsy, because here you can see this looks like an endometriotic implant that you can also see in the peritoneum. But of course, I can also understand the patient. She said, no biopsy from my eye, you know. So what I did was I put her on Dianagist, and already next cycle, which wasn't the cycle because she only had a little spotting, she had no symptoms. So the eye did not turn red, and she is now for quite some time on Dianagist treatment and has no such problems anymore. So in the end, we will not know whether this was endometriosis or not, but it is absolutely obvious that this might be endometriosis. Now, another case, this is not from my consultation, but from Japan. Dr. Harada had a woman. She had rectosigmoid endometriosis, deep infiltrating endometriosis, and this woman refused surgery. And I'm sure also in your consultation, you will come across women that are afraid of surgery and say, you know, I better die than having a bowel surgery, especially if you have to explain to her in the informed consent, maybe you have an ileostoma. You know, this is the worst imagination that a woman can have for this. Now, what Dr. Harada did was a biopsy was taken to prove that since it was a tumor of the rectus sigmoid, that this tumor was not a malignancy. Because all of you know such tumors can be malignant, but also, and I had such cases as well, I had the mixture of an endometriosis with a malignant part of an endometrioid cancer of the bowel. So we need to know this. So a biopsy was taken, and this woman was treated for some months with a dianologist. And as you can see, this is the initial stage, and this is the stage after a few months. So we must admit, dianologist is not a miracle drug. It will not sort of evaporate the endometriotic implant of deep infiltrating endometriosis, but it reduced the size. And most importantly for the patient did not have any pain. And we know, and I can also support this from my personal experience, dianologist is very, very effective in reducing pain. Now, I mentioned that probably the ESHRE guidelines might have to be reduced, and I'm proud that I can share a few hot topics with you, and one hot topic is this publication. It is an EPUB ahead of print, and you can see this is from 2017, and it says progestin-only pills may be a better first-line treatment for endometriosis than combined estrogen progesterone contraceptives pills. We knew that from before, but this is now a very good analysis, and this is a clear indication that particular dianologist is the best option if you want to treat endometriosis, much better than other progestins and much better than combined contraceptives. The next hot topic that I want to share, and I am authorized by Bayer to do so, not by Bayer Turkey, I don't know, we didn't discuss this, but by Bayer Germany. And as you know, research is always not only very difficult, but it's also very expensive. But this is from the pipeline brought to you. There is a new substance in the Bayer pipeline at least, and this is a novel non-sex hormonal approach to treating endometriosis. And you can see again, it will be an inhibitor of the local estradiol production, and it will also reduce inflammation and proliferation. That is what we need, a non-hormonal substance. So that might be sort of the follow-up of dianologist, but it might take still quite some time until this is available. And you can see here that the total lesion size reduction, and you can see here this is only a vehicle, and I think this is probably from the distance hard to see. It is very difficult to see, but there is also a reduction in the size, and this is around about 68%, which is comparable to the in vitro studies of dianologists when this was done in egg yolk cultures where implants of endometriosis were seen and the reduction of the growth of vessels were seen. So I'm coming to the end of my presentation, and it's my pleasure, and I'm very proud to be here also to introduce to you the 4th European Congress on Endometriosis, which surprisingly enough will be in Turkey, in the beautiful city of Antalya, and the president of this conference will be Professor Engin Oral from Istanbul. And coming to the end, I'd like to thank you very much for your kind attention. Thank you very much.
Some questions, but before my question, do you want to ask any question to Dr. Tinneberg? He is one of the renowned experts in the world about this subject. his center, one of the major endometriosis center in Germany. How many endometriosis center in Germany?
I think in Germany we have about 8 centers.
8.
That there are 3 levels of endometriosis centers. The very simple ones, or the basic ones, are the ones that just consult patients and then they refer patients. The next one is that do also surgery, but they do not do surgery of deep infiltrating endometriosis. And our center operates mainly the ones that had been operated on, including also the ones with nerve infiltration, deep infiltrating endometriosis. And I don't know whether you came across women that have deep infiltrating endometriosis of sciatic nerve or of pudendal nerve. This is very challenging. It is pumping up my adrenaline level, but I'm doing this surgery together with our neurosurgeons, which also do the implantation of electrodes.
Any comment, any question? Jeff? Mikrofon hızla getirir misiniz?
Thank you so much. In case of deep infiltrating endometriosis, those cases who are not operated, how will be, what is the effect of Dionegas? What do you think on the pain elevation with Dionegas in such cases? No operation, but they have deep infiltrating endometriosis. Do you have any?
I'm not sure whether I understood your question correctly.
Cem, just louder.
In cases with deep infiltrating endometriosis, but who have not been operated for.
He's asking about the deep endometriosis. Do you use the Dionegest in this case, or how long? Right?
Thank you. Is that correct?
No. For cases who are not operated, but they have deep infiltrating endometriosis. And we sometimes give Dionegest for such patients. What is your experience? Do they have some sort of pain elevation even in such scenario?
Well, women with severe deep infiltrating endometriosis that I have seen have, and that had been subjected to a Dionegest, at some stage come to the conclusion, and that's probably because I only see those patients, that then have to be subjected to an operation. And what we do in these cases is we operate them, and then they are put on Dionegest again, because it is better tolerated than GnRH analogs. And
if we cannot do any operation for this patient, do you use medical treatment, Dionegest, directly for this patient?
yeah, but what
Deep
would be the patient
endometriosis.
we cannot operate?
Maybe she has some contraindication for surgery. Maybe she doesn't want to do operation. In Turkey, for the deep endometriosis, the patients afraid of them because of the complication rate. We say the complication rate about 10%. That's the reason. And as you know, this is a very highly trained surgery. That's why we can choose medical treatment.
Yeah. Well, it always depends on at what stage the patient is referred to you. Unfortunately, especially with the very severe deep infiltrating endometriosis, I'm sure you know too. Sometimes the ureter had been blocked and they have a silent kidney. Sometimes the nerves are affected, and I've seen recently a woman that was limping. She couldn't walk because the sciatic nerve was partly damaged. So very, very bad cases. And in those cases, even though they might be afraid, and unfortunately the diagnosis is delayed, we have to do the surgery. I would not advocate to only treat deep infiltrating endometriosis with a drug, even though it's a good drug, like Dionegest, because the endometriosis will stay, as you could see also from the slides of Harada in Japan. This might be a good way to sort of save time and reduce the pain of the patient and to go ahead. And depending on how old the patient is, if she is close to 40, then you might cover enough time for her to enter menopause, which then might also allow her to be pain-free. And we know from Japan, where this drug is on the market and available for the longest time worldwide, that they have patients that used Dynagest, it's called Dynagest in Japan, for several years with good results.
We have to use the Dynagest as the more than 2 or 3 years. And for example, in our country, we have this drug 4 years. I have patients, not too much, but some patients, they are using still on Dynagest therapy. Do we have to use it with safety?
I have one patient, she came from India, and she was put on GnRH analogs, so I changed her to Dynagest. She's absolutely happy, and she has this now, I think, for three and a half years or so. And she will continue having this for long because, I mean, she's just fine.
Another question, in your routine practice, actually, which patients is candidate for the OC, which patients candidate for the progestin?
Well, as I said, oral contraceptive seems to be a reflex. The first idea when, especially a young woman is coming to consult you, is combine oral contraceptives. So my feeling is also take into consideration all the data from the literature that we have, that if a young woman, a girl is coming to you, maybe 13, 14 years of age, and is complaining about severe dysmenorrhea, so the first choice will be to put her on oral contraceptives. And at that young age, I think it should be combined oral contraceptives. Now, if this young girl is not relieved of her pain, then one has to change the protocol. And one might change to a progestin-only pill, but, I told you I'm a surgeon. I would prefer to perform laparoscopy and check whether there are implants, remove those implants, and then have a specific therapy, which should then, a Dynagest-only substrate.
Okay, when you choose the OC, do you prefer OC containing Dynagest or the other ones?
No.
Is there any difference between them?
Well, the data from the literature show that Dynagest is the only substance that had been sufficiently investigated to demonstrate that there is the anti-inflammatory, there is the anti-proliferative, and there is the immunoregulatory effect. So when applying a contraceptive, it has to contain Dynagest, and I think this is quite obvious.
If we can choose the OC, do we have to choose A2 level is 20 microgram or 30 microgram, ethyl estradiol or estradiol valerate, which is difficult, tough?
Well, I think it's better for the patient to have a lower estradiol. They need some estradiol, especially the young patients. But if you can have estradiol, it's probably more comfortable for these patients.
I mean the low dose or the 1 or 2 milligram or the 20 or 30 microgram for ethyl estradiol.
No,
is it
I would prefer a lower estradiol
yeah?
level. Mm-hmm.
Okay. I will continue, but do you have any question?
I want to ask you that, what do you think about the use of GnRH antagonist in the medical treatment of endometriosis? As we know, a new drug has been recently announced. So would it be the better way, or could it change our practice?
He is asking about the GnRH antagonist, which is called elagolix, right?
Oh, okay.
Right.
Elagolix, right? Do you think, is there any hope for this one in the future? He's asking about it.
Well, I think the agonists are always difficult to use. Pardon?
GnRH antagonist.
The antagonist.
Antagonist, yeah.
Yeah, there are some studies where antagonists can be titrated. And with titration of the antagonist, you can sort of also increase a certain background level of estradiol. So, there are no data available yet, but you're talking about future perspectives. This could be an idea to sort of titrate the level of the antagonist to to an amount whereby there's enough background production of estradiol, so also to help these women to be relieved. But this is only the idea. I do not know of any studies that support this, but the idea is wonderful.
Another question, comment? She is 26 years old. She just came to your office. She is 26 years old. She is single. She has no endometriosis at the ultrasonography or MRI, it's up to you. But you can smell the endometriosis, but there is no proof. And do you prefer empiric therapy, or if prefer, which one? I mean, in your practice, in Germany practice.
Well, you only mentioned the imaging for endometriosis. So what I
there is no endometrioma in there, and there is no deep endometriosis in ultrasonography. She has good candidate for chronic pelvic pain, but some symptoms looks like the endometriosis she has, but there is no proof. There is no surgery in her history. You want to use the empirical medical therapy. Do you want to use it?
Well, first of all, I would also examine rectovaginally.
Yeah,
and
that's important.
you probably do the same. So by rectovaginal examination, you can do a pain mapping. And in particular, the uterosacral ligaments, they usually are very tender in case of endometriosis of the pouch of Douglas. I think you probably do all the same. If not, please do so, because this is extremely helpful. Now, I smell the endometriosis, and I do not want to subject my patient to the surgery, even though I love surgery. I think a 20-year-old patient, I would first put her on oral contraceptives. If the oral contraceptive does not have the effect that I want with this patient, I have to see her again after 2 cycles, and if she says, "Oh, it's okay, but I'm not happy," then I would directly put her on Dianogist. In case also Dianogist would not be effective, first of all, we have to consider other reasons for chronic pelvic pain. And I do not know whether you're aware of the fact that, for instance, sexual child abuse is responsible for a lot of women with chronic pelvic pain. The figure that I was given by our psychological traumatologist is that 30% of women with chronic pelvic pain had episodes of sexual child abuse. So therefore, this need to be taken into consideration. Yeah? And in those patients, of course, laparoscopy doesn't help at all, too.
Another issue, last 5 years, the literature is changing about the medical treatment. Maybe you can approve or not. In my old times, GnRH was the king. Now, it's place of very small, according to my knowledge. Now, OC versus, in the last 5 years, OC versus progestin. Nowadays, last 2 years, now it's changing to the only OC, only progestin pill. But the problem with the progestin pill, the side effects. 2 main side effects that I see in my practice. The first one, body weight. The second one, mood change. How can you handle this kind of patients with this one for the long-term medical therapy?
Well, first of all, I did not experience weight gain. So my patients do not complain about weight gain. Secondly, the problem of mood changes is severe, and especially women with a history or a family history of depression, they are susceptible to this. But when I prescribe the progestin only, or let's say Dianogist, I tell them quite frankly, please be so kind not to judge this drug until after 3 months. Because in my experience, and I don't know what your experience is, if the first 3 months are overcome, then the patients are very happy with this drug because they realize that there is no more pain and they feel much better. And also the changes, the adaptation to this substance is quite effective. But the first 3 months can be difficult, and they complain, oh, I'm dysphoric, I see only gray, and I have these spottings. After 3 months, this is by far less.
Do you increase the diagnosis dose when you have the breakthrough bleeding? And do you increase dose? Is it useful?
This is what I tell the patient, to increase the dose, 2 tablets for 3 days.
Just for 3 days.
Mm-hmm.
And after that, again,
go back to normal.
Go back now, just 2 days. Because Romer prefer 1 or 2 week, 2 tablets. He says one of the lecture, he is using 2 tablets, sometimes 3 tablets, 1 or 2 weeks. After that, again, 1 tablet per day.
Yeah. Well, again, in my experience, there's no need of increasing the dose to 6 milligrams. That's what it would be. And then, if I would apply 6 milligrams for a longer period of time, I would concern about some liver toxicity, in a way that every hormone does have a liver toxic effect. So I would rather stick to short time increase of dose.
If I say, Dr. Tinneberg, when I give the lecture to my assistant and students, I am saying we have 5 different endometriosis: superficial, endometrioma, deep, adenomyosis, and extragenital. Is that correct? And for the extragenital and deep and adenomyosis, progestin is the number 1. Either progestin on the pills or progestin releasing IUD. Did you approve this sentence?
Yeah. As a matter of fact, there's no proper treatment for ovarian endometrioma. So the best, of course, is to remove ovarian endometrioma. But since this is a reproductive medicine congress, you all know that one should not operate on ovarian endometrioma if the endometrioma is relatively small. I think reproductive techniques are much better in that case if it is not too big. But on the other hand, if there is a lot of pain just because the endometrioma is really big or is kissing ovaries or is attached to the bowel, then of course I think surgery is an option. And I think the following presentations by Arnaud Vattier will also show how you can deal with these problems nicely.
Last question for me. Recently we learned the diagnosis of adenomyosis, like in Turkey, in the world. I don't know what is the position in Germany now, but we have a lot of adenomyosis patient which is infertile. And for the long-term follow-up, do you use medication for this one? She has diffuse adenomyosis, and she is single or she is not fertile. Do you use medication? Of use which one? Do you have used this kind of patients? You are a surgeon, but maybe you can use it.
Well, first of all, I think a large proportion of women with adenomyosis, they had children. And there is the concept that the basal membrane of the endometrium got fragile, and therefore there is an invasion of endometriotic cells into the myometrium. Now, it depends on whether the adenomyosis is diffuse or is focal. And I'm seeing a lot of patients referred from even distant areas that come even especially for the diffuse adenomyosis, because we have advocated the Osada technique with the modification that we do in my department. But in many cases, there is no way of treating this. And since you were saying these are infertility patients, of course, Mirena doesn't work in those patients, and Mirena does not have a long-term effect. So we only would have 2 options for short-term effect, and then hand them over to the infertility specialist. And that could only be either dianagist for a certain period of time and or GnRH analog for a certain period of time. In those cases where there is infertility is a very important diagnosis, I personally feel that this is the last resort for GnRH analogs, because treating those patients with GnRH analogs, you can suppress them, you can sort of open to a certain extent the implantation window in the uterine receptivity, and then, you know, from the downregulation using GnRH analogs, you can then start stimulation immediately and have either spontaneous conception or IVF procedures.
Thank you. Any question, comment?
Thank you very much for your nice talk. My query is, DNRGS is really a good alternative for the treatment of endometriosis, but whenever I think about the treatment of endometriosis, I think about, as you said in your speech, we have to stop the retrograde bleeding during menstruation. So the oral contraceptive pills, usually the continuous treatment regimen, comes forward this way. What we do with DNRGS is usually to prevent anti-inflammatory effects and the other pathways that you explained. What about the levonorgestrel interferon system? What is it in your practice, and leading to amenorrhea with levonorgestrel, including intrauterine devices, might be a good preference for the prevention of endometriosis lesions?
Just to sort of repeat your question, so what is the role of, let's say, Mirena, and what is the comparison of Mirena versus DNRGS? And as you all know, you know, when you have a Mirena, it is not a local effect on the uterus only, on the endometrium. But there the effect is more pronounced. I mean, you can put Mirena also in the abdominal cavity and it will have a contraceptive effect, and this has happened often enough by misplacement of Mirena. Now, levonorgestrel is not as effective in treatment of endometriosis as is DNRGS. So depending on what case you have, I would still recommend preferring DNRGS. However, if you have a patient that is not requiring infertility treatment with an adenomyosis or with a suspected adenomyosis, then of course I think the Mirena is a very good treatment option. Yeah.
Dr. Tinneberg just came for one day for this conference. Thank you so much. It's a long journey. Thank you for supporting us by our team for this symposium. Again, thank you so much for being us, and we will continue without break for the next session.